Ma'am at Active Karya. As we know, the topic for today's discussion is family-centered care across various pediatric physiotherapy settings. Now, when we say family-centered care, we recognize that the family personifies or behaves as a constant in a child's life, and therefore, this concept truly facilitates a parent-professional collaboration and just does not merely rely with just coordination of services. So basically, it encourages a mutual beneficial partnership between the healthcare professionals, patients, and families. When we take this concept and we apply it to our pediatrics, so when we say pediatric, we think children, but then turns out it's a whole different ball game, because as we know, PEDS is not just simply, it just doesn't encompass a small population. It is a whole wide spectrum. And there are different ages, which also personifies the different categories and stages. So when it starts as small as neonatal. We have our 0 to 3 months, which deals with early intervention. We have our preschool age, that is 3 to 5 years. Then we have 5+, which we say as school years. Then comes the teenage years. So as you see, it's a whole spectrum. And each and every stage comes with its own nuances. So since it is such a diverse setting, we also have diverse panel member today. So there are 4 esteemed panelists today representing the diverse settings in which they have their expertise in. So before I introduce these members, there are a few instructions for the audience. Kindly mute so that, while the session is going on, so that we avoid any ambient noise disturbances. As the discussion is going on, participants are requested to drop any queries in the chat box below. We plan to wrap this discussion in like about 40 minutes and then again open it back for the audience to join in with queries. So without any further ado, I welcome our panel members. I'll start with the senior most. Ushma ma'am?
No. I'll be the last one.
No, ma'am. Just introducing you guys, not the questions as such now. Okay. So we have Ushma ma'am, we have Pooja ma'am, we have Dr. Rajita, as well as Sundar sir here. My first question basically is, what is the setting? Like, what is the setting where you work? Please kindly give an introduction first, and then we'll proceed with what is the setting where you work and the type of clientele that you treat. We can begin with Dr. Sundar sir.
Okay. My area of expertise is I work with children with cerebral palsy. There is a wide range of clients that I treat: cerebral palsy, autism, ADHD, genetic disorders. I work in NICU. The range of clients that I treat is I start from premature infants and then it goes till 21 years. The youngest one is 21 years that I treat. So that is my clientele base. I have around 20 years of experience working in the field. And the other thing is, I own a private practice. The private practice name is Therakinos. This is where I treat, but I also go as a visiting consultant to places like Bijapur. If people know about it, it's in the northern part of Karnataka. And then I also go to a place called as Raichur. There are 2 lovely children-based hospitals where I was personally involved in NICU care in these 2 hospitals. But we also do a lot of an outreach work for around 200-300 kilometers in the surrounding area, working with families who do not have these kinds of luxury and support that we have in the urban setup. So that is my area of expertise.
Okay. Rajita ma'am?
Good evening all. Am I audible?
Yes ma'am, you are.
Okay. Good evening all. I'm Rajita Alva, working currently as an academic faculty at Department of Physiotherapy, Ramaya Medical College. So my clinical practice predominantly in an acute care setup. We cater to a very diverse population, patients ranging from high-risk infants who are NICU graduates to other chronic conditions like pediatric oncology, renal disorders, and other illness like epilepsy, lots of other conditions, meningitis, encephalitis, etc. Because predominantly I practice in a tertiary care hospital. So you could imagine the population who could availing the service in a tertiary care hospital. So you can also think that these children would require ongoing medical treatment. Example, if we consider a childhood cancer, they need every systematic medical treatment. Even high-risk infants, they require a long-term follow-up in order to understand their developmental and overall development, etc. So we may not be able to cater this few of the chronic illness in terms of a clinical setup. They need to be rehabilitated in an acute care setup. So because they require a medical monitoring, there are multiple aspects that we focus on in terms of rehabilitation, my team, early intervention, quality of life, physical activity level, etc. So at the same time, we are all, since some of these are untouched area, like a chronic condition like pediatric oncology and renal disorders are important, physiotherapy role, and definitely the involvement of the parents. Since these are untouched area, we are also trying to establish few data in this population by conducting various research so that we could share our outcome with the larger community, how actually we are trying to benefit these children, also their family. So this is what my clinical practice currently.
Thank you, Rajita ma'am. Pooja ma'am.
Hello, everybody. So my name is Pooja. I basically have a variety of experiences. I have a master's from the University of Illinois at Chicago. And after that, I worked in the early intervention systems in the US for a while. I was also doing a few hours of aquatic therapy there. And then coming back to India, I did a lot of work with parent support, parent education, family-centered care in, I would say, 0 to 5 years. We did a lot of work with, just doing a lot of workshops for parents and professionals. And then for the last 6 years, I've been working in an NICU. I work very short hours, so I don't have a lot of variety in my, clientele. I think the oldest, child I treat would be 2.5 years. What else did you want me to say? Introduction and area? Yeah? Okay, that's it. Thank you.
Yes, ma'am. Pushpa ma'am?
Yeah, hi. So just to add that Pooja is a known friend, and I have to add two things that she has worked with. While in the University of Chicago, she has worked with the great Suzanne Campbell, okay, the author. And you can imagine her situation over there, how hard it would be, a great learning experience, but also very hard and trying, to work with the best known physiotherapist in pediatrics all around the world, So Pooja has worked there. And also Pooja is one of the persons who started offering online services, online help to parents of infants and young children, even way before the COVID. And she and I think some of her friends established a very good platform, which probably doesn't exist right now, but they did it. So I learned a lot from her. Okay. So me, yes, I'm Ushma Goradia. I also have a variety of experiences because I have worked more as a pediatric therapist for more than 30 years. And, in all sorts of situations, in early intervention, in acute care, in, as a school therapist. I also have done adult rehab. So I'm able to translate, adult to child, child to adult, practices or techniques or whatever you call the clinical reasoning. That has been my strength. But right now in Bangalore, I've been in India since the past 10 years. I run a private practice, Active Karya. And although I do see children of all ages up to maybe 10 or 12, I mean, including the youngest babies, but my large part of the practice is the preschool age children, that is children from 3 to 5 years of age, also sometimes extending to 6 and 7. And earlier in my career, I mean, the first half of my career was, again, as you know, just like other therapists, their experiences, a range of diagnosis, range of conditions in variety of situations. However, now in my private practice, I have to admit I am selective because I'm getting older. Okay. And I am being selective. And I see children with mostly with autism, ADHD, sensory processing dysfunction, which is now called sensory processing differences. But you know, I focus on that because I have had the opportunity to learn with OTs a lot and be by their side throughout my career in the United States. So I love the sensory part. I'm not NDT trained, but I've also attended many NDT courses. So in my work, I combine the three main topics I love, and I combine in my work is sensory integration, NDT, and motor learning. These are my three heavy areas. I believe in all these three, you know, heavily, and lean on it during treatment. So, and some of the children who come to me are like gray area children, whom I call, that is, they are going to grade school, you know, the regular schools in Bangalore, but they can't function in the class. So that is why these children get referred to me, and I test them, evaluate them. Why can't they function? And then I take it further from there. And then, yes, we see a lot of improvements with our treatment that we do in our clinic. So that is my, you know, my intro, and we'll move on to the Sharon. All up to you.
Rajita ma'am, as you just described, you are attached to the hospital, which I guess it represents the entire spectrum that we were talking about, from the babies to the, you know, to the, we have seen even the age of 15, 16 as well. But then we know we do closely work with the onco section and the renal, as you pointed out. So, ma'am, the second question is, what are the two to three parental concerns that you come across frequently, apart from all the others?
Thank you, Sharon. Before I go to the clinical parental concerns, I'd just like to highlight on the, you know, stats aspect in terms of the, that I think that would give the audience a better, you know, parental concerns orientation. So basically, in terms of onco and nephrology, we do see them in terms of mostly in terms of inpatient, and a small amount, number of children we cater them in the outpatient also. So in about in a month, I see around 30 to 40, around 50 kids we see in terms of oncology and nephrology. The parents really, you know, most of the parents are think, or they are unsure about the level of the physical activity the child can perform on a regular basis. And there are multiple, there is a sub question I can put across actually. Post chemotherapy, my child can, whether a child can walk, whether a child can do that activity, this, and also to school going concern, like can my child go to a school? So these are the major concern, especially oncology and nephrology. Even the renal cases, the childhood renal condition, they're on treatment of steroids. So most of them have, as we all as PT, we can relate their, impairments, right? So most of they come out of these are the concerns. What is the level of physical activity the child can perform? And is it okay to go to the school? What they can do and don't, those kind of questions. Another population I would like to mention the parental concern is high-risk infants. We also have a huge practice in high-risk infants. Actually, the NICU graduate. So we actually follow them after around 1.5 years or so. So most of the parents always ask, always worried about the overall development of the child. So this is a major concern in terms of iris. Another major population we see is the epileptic disorder with the developmental regression. So this is the parent has a wide variety of question actually. So most of the time we are really unsure about how to answer about their queries. So basically the question, I think we all can relate again their impairments. So mostly the parent are concerned about their, when would they start developing that particular domain, be it motor domain, be it speech, language. This is a major concern about the epileptic disorder with the developmental regression. So I pointed out three areas parental concerns. The first one is oncology and nephrology, childhood, parent concerns. Another one is iris population parent concerns and epileptic disorder with the developmental regression.
Thank you, Rajita ma'am.
Thanks.
Pooja ma'am, the same question to you.
Yeah. So because I work with very, very young infants, and especially in the NICU, I think the first thing that parents are, I wouldn't really call it concern, but what they feel is scared, they're scared for the baby survival. They have never seen, 1 kg, 1.2 kg, kid with, it's just not a sight that people have seen, right? So parents are scared. Obviously, there's a lot of stress associated with being in the NICU. So I find that a lot of times the concerns come from that space, just fear whether my child is going to survive, are they going to sort of go, to the next stage of independence? If they're on a ventilator, will they breathe on their own? If they're feeding with the tube, will they, go to breastfeeding, stuff like that? If the mother can then, produce enough milk to feed this child, stuff like that. The other, once they're sort of out of that, critical medical sort of phase, and they're growing and thriving, and they're, going to go home with the parents, I think the concern then becomes, can they handle this child? Maybe they're going with, just enough weight gain so that they don't need to be in the hospital, but they're still a little concerned, so in the hospital, they have nurses to help. If they are feeding, having an issue with feeding, will they be able to replicate that in the house? Will the child sleep, in the same pattern that they were doing in the hospital, so on and so forth. So a lot of issues with self-confidence, self-efficacy, for the parent. And then once they get past that phase as well, once they're settled in the house, then exactly like Dr. Rajita said, for the high risk follow-up, they are concerned about, how their child is doing. However, I do find that they don't really understand the difference between growth and development. A lot of them are just concerned about weight, weight gain, or they assume that if my child is, gaining weight and growing in that sense, or, the motor skills or the language skills will follow. So that's another thing where, we have to really figure out how to give them that information and get them through that. So, yeah.
Thank you, Pooja ma'am. Sundar sir, the parental concerns that you frequently come across?
Yeah, being in an outpatient pediatric unit, rehab unit, some of the questions are going to be pretty common when families come and ask questions, because they are not going to ask anything about the medically compromised aspects, like, what do you see in an EQ? But when they come to OPD, the reality sets in. So they would ask real questions. One of the commonest questions, I'm sure that many of the therapists sitting here would eventually come across, parents asking you is this: is my child going to be normal? Because normality is everything in our society, right? Is my child going to be normal? Normal in the sense is just saying that is my child is going to be like every other child going to the school. having an education, clearing the academics, finding a job. That is the question that they're going to ask. So that is the toughest question. And I think every practitioner should be prepared to answer that question, because you have to take it head on. You cannot dodge that question and say it's going to be okay, we are going to wait for some time. So I would be addressing that in the next thing. There are ample of information that we have of how to deal with families, but this is a very important question. The second question that families would ask is, what is the time frame? What is the time frame that how much time it's going to take for my child to achieve this? Okay, you're going to say that we are going to work on this particular goal, but what is the time frame? Now, can we realistically talk about time frame? I would say yes. Should be, as a practitioner working with the child over a period of time, should be able to tell the families that how much of a time frame that it might take, right? That's number one. But there are many factors that can influence this time frame. So as a practitioner, we should understand what influences this time frame. How to engage the families in making them understand that how much time it's going to take. That is number two. Number three, there's a very specific question that families would ask me, especially children with spastic diplegics, is this: when is my child going to walk? Or they would say that we right from a very engaged 6 months, 7 months, we started therapy. Today, my child is 7 years, still he is not walking. When my child is going to walk, what should I do? So there are many questions, but I thought these are some of the basic questions that we as a therapist should be able to easily answer them. So that is why I put these three questions. Probably in the next session, we will open up and discuss about answer for these questions.
Ishma ma'am?
Yes. So thank you, Sundar. Sundar and myself both are in outpatient private practice. Well, he does a lot more though, but since both of us are in outpatient, we have the same overlapping questions, particularly the one that which school should my child go to, or what is your suggestion or your advice, which school, what kind of school should I put my child? Or they come out straight with, why cannot my child go with mainstream school? We will do therapy for 1 year, 2 years, 3 years, whatever it takes, we will do. But why can't my child attend mainstream school? And this is not only for children with autism hyperactivity, it's also children. I also see a few children with cerebral palsy and, just like Sundar. So the same questions parents have. Because we all know that along with cerebral palsy, there are many other issues that the child has in speech and language and functioning and cognition and emotion and many other things. But I think parents need to know that that just because a child is walking or will be able to walk someday, maybe next year, maybe 2 years after, they cannot go to a normal school, or they can go. That is the thing. Being a physical therapist, this sort of, I laugh at this time inwardly all the time, because the first thing parents tell me on the phone or when they come and see me the first time, ma'am, physical is all okay, no problem. Physical is, everything is fine, but my child does not speak, has eye contact issues, attention issues, and mainly does not mingle or play with other children when I take them down, to the apartment, complex or whatever. So that mingling, now parents are realizing that the child is not mingling or playing with other children, or other children come and play, but my child does not know how to respond to them or mix with them or mingle with them. So that is the top question I get. And the other question I get is, the child does not sit. So how can we teach ABCD to the child? So these are, my top 3 questions, besides that normal schooling or mainstream schooling or with schooling. Okay, that a child does not sit. So how can we teach them ABCD? And believe me, these are the exact words that I get to hear. How can I teach my child ABCD?
Okay. Thank you, ma'am. Sundar, so back to you. You just mentioned one of the primary concern is, will my child be normal? So that is a very profound question that we come across. So going forward from there, why do you think, sir, the parents have these concerns, like the one that you addressed? Because your answers and the answers from the panels definitely will give an insight to the audience about the perspective from the society as well. So to you, sir.
No, the number one thing is the social pressure. Okay, now as a family member, I can understand if I have to take this kid to go for a social gathering or a party, that then becomes it. The family is subjected to an immense pressure of answering every peer, every family member or every relative to say that what is going with this child. Now that is the main concern the family has. The family always wants to come out and then say that no, my child is normal, my child is going to the school like in every other kid. So it's like they are not worried about what has happened during birth. They are not worried about what is the MRI says. The only thing that they have a hope. They have a hope, immense hope that someday at some point of time things are going to be normal. Now that is what they wanted to hear, right? So when they come to you, that they would ask, okay, is my child is going to be normal? The moment you say yes, your child is going to be normal, they are going to cling to that hope. But please understand that we have to be extremely careful when we are using such kinds of words, when we are speaking with family members. We cannot give false hope to them, right? So there was this one beautiful paper by Aina Novak. Aina Novak was a great researcher. I love reading all her research work. And one of the research work that she did, she talked about how to convey the diagnosis to the family members and how it is important to talk about that and know how could be the future of the child to the family member. It's so important that you talk much earlier. You don't keep them, you don't play a hide and seek game with them, right? You talk much earlier. It's going to be tough. It's going to be hard, but you have to talk to them, because if you're going to talk late, the Aina Novak's paper talks about how that has caused talking at a later phase puts them under an immense pressure. Families go through psychiatric problems. Families go through a lot of a depression. So this is pretty important that you talk with family members pretty early, right? That's number one. But if you have to talk to the family members pretty early, as a therapist, I need to be really equipped with certain tools, right? Now, there are various tools available today. Now, say for an example, if I see a child, now, one of the things I do is I see babies much earlier when I go to the outreach places, right? So I would do a lot of GMs and then I do a lot of HINE. These are one of the best screening tools that are available to identify children's at risk of development. That's number one, especially the physical part of it, right? So when I do this screening, but this screening also gives me an ability to predict what would be the outcome at 2 years. People who have used it would really understand that the power of these tools to predict at 2 years. So if I see a child with a high score of less than 30 or less than 40, I'm sure that this child is going to be sick. So I have to take time to sit with families to make them understand that this is going to be very severe. There is a possibility that this child may not walk, or there is a possibility that this child may have to walk with assistance. They have to use assistive devices. So what that puts is, it puts a clarity in their head. Yes, at that moment, it's going to be hard for the families to digest, but once the reality sinks in, they would take clear decisions with regard to the child's future. Imagine if the family comes in a high score of 30 and you're going to put them on a false hope that this child is going to walk at some point of time. You are going to put them in an immense pressure when the child reaches 5, 6 years, 7 years, and 8 years, because they would continue to still have that hope. Please understand that. I'm not saying that the child would never walk, but based on all the evidences that we have, we should always be realistic in telling them that what's going to happen with their child, what is going to be the future with their child. Now that is why that puts them well prepared either to buy a standing frame or to buy a wheelchair or to buy things that are more essential and important for the children. That they would miss out if we are not giving them right picture about the prognosis of this child. That's number one. Number two is the time frame. Right? When we are looking at the time frame, families would always come how much time it's going to take. Now, one simple example is one of the researchers that I studied about the upper limb goals in children with cerebral palsy. So this beautiful paper talks about it requires 25 hours of goal practice. 25 hours of goal practice to achieve that goal. If your goal is pretty much functional. If you're looking at a functional goal, not a movement goal, please understand this. This is the functional goal. If you're looking at a functional goal, it takes 25 hours of practice. Now, 25 hours of practice can be done in the clinic, or it can be done in the home, or it can be collectively done in the clinic and the home. Please understand that. That means if I'm going to do it in the clinic and the same thing is practiced at the home, that 25 hours is going to be achieved in a short span of time. You agree with me, right? Now, that is what families need to understand it. I always tell the families is please understand that bringing your child to the clinic is not your responsibility. Your responsibility starts once you enroll the child into the program. Getting into the program is not your responsibility. Paying the fees is not your responsibility. Those are not responsibility. But actually working with your child is your responsibility. So there are multiple factors. My expertise, the family's interest in working with the child's learning pattern. Please understand the personal contextual factors. If you look at ICF, there is a contextual factor. Now, what is the context? How motivated the child is, how the environment is facilitating. All that is taken into consideration when you're looking at the time factor. So I would in detail sit with families and make them understand this. This is how it works. And then if all we put this puzzle in place, 25 hours would be a realistic time to achieve a certain goal, right? Even though it as a paper talks about an upper limb goal, it's going to be for every little goals that you set up. Even if it's for a goal as standing as a goal or a gross motor as a goal, but it should be functional. It is not just movements. Please understand that. So we are talking about functional goal. That's number 2. Number 3 is when my child is going to walk, right? That question is pretty huge. Now, there are 2 factors I would tell therapists should always keep in mind. I would always tell 2 things. One is look at their trunk, look at their feet. If they have a very bad feet, if they have a very bad postural control in their trunk, this child is not going to walk unless and until you find a way to fix it, right? If the child is going to have musculoskeletal deformities, the child is not going to walk. No matter how many years of practice you're doing it. If they have lots of musculoskeletal complications, they are not getting into a better alignment. If they're not going to get into a better alignment, they're not going to walk. As simple as that. If they're already walking, if they are in a bad alignment, I would say to the family, this child is going to lose walking once they put on weight, once they attain puberty, it's going to be tough on them. So all this we have to keep in mind when addressing these questions. I'm sure that there is a lot of an answer. I can go ask and ask to speak about it, but in a short span of time, that is something which as a therapist we need to understand. We need to be mindful when we are speaking to the families. But I would always say that we should be as realistic as possible when we are speaking to the families.
Thank you, sir. Rajita ma'am.
Sorry. Yes, Sharon. Yeah.
Yeah, ma'am.
Same question. Yeah.
Yes, ma'am.
Yeah. Okay. I think Sundar sir has covered in terms of high-risk infants and epileptic disorder the answers, I guess. So let me highlight on the oncology and the nephrology as part of it. So I consider as a multiple reasons why the parents are concerned about their level of physical activity or going to school, etc. One of the most attributed factor could be a multidisciplinary team practice, because what happens, most of the parents, they consider that managing their medical condition as a top priority on the on the process of the medical treatment. They actually forget about the other health status of the child, like for example, be it fitness, be it their level of physical activity. That is not a priority at all, because even in terms of the medical practitioner, they will not highlight upon those aspects, because the main illness is, as we call it, as a cancer, right? So they probably treat that aspect, and parents are not really given a counseling or an orientation in terms of those aspects at all. So only when they get admitted, in my practice, when a patient get admitted, I get to see them. That is only when actually I get to counsel them. But it doesn't happen in the day one. So that's the main reason actually the parental concern remains the same. Actually, will my child would be able to walk like the other, the same age children, or my kid will be able to go to school. As evidence suggests that most of the kids actually, when they at the point of a diagnosis, they have a really good physical activity and fitness level. But as they actually go in terms of their primary treatment and their maintenance phase, that is when actually they lose out or they phase out their physical fitness level and activity level. So that's mainly because what is happening at the point of diagnosis, we never thought about actually counseling the parents about these aspects at all. Had we counseled in terms of their, during the point of diagnosis, these concerns wouldn't have been arised. So as a PT, we have an immense actually role in terms of counseling them in the really, really very acute stage of their diagnosis. So if we're doing that aspect, I don't think so we have to really concern in terms of their medical treatment phase, because the parents are oriented and the family is oriented. So really that goes into a very easy part or easy path. So there are many evidence says that actually the family involvement happens in the later part. In the initial part, most of, I'm talking again coming back to the physical activity and the fitness level. The initial phase, it's always a medical treatment. So the health status again and the quality of life is really goes and tossed by the time they come into a maintenance phase. So as a team, I think as a profession, we have these. This is one of the untouched area. We have to think about developing the multidisciplinary team practice and educating our physiotherapy importance to those consultants who are practicing in this area. I think after that only we could touch in terms of the parental concern. I think that is the secondary thing which is coming here, because the parental, in order to educate the parents, we have to educate the primary consultant. So I would look at into that aspect rather than only saying that this is concern is only coming because of the parents also. So if you have to educate the parents, we have to educate the consultant who are actually working in the specialty area. Another concern, these high-risk infants, basically, they always ask about their overall development. I cater to a bit of low to moderate socioeconomic, population. So most of them are coming from not very higher educational, education background. So having one or two counseling with them regarding the child development may not be sufficient. So ongoing team counseling with the parents. Here also there are a lot of evidence say that the family counseling, ongoing counseling really helps the getting the family orientation and the child, them understanding the child development. So we need something called ongoing counseling. Probably we need to develop ourselves a support group to them. So until unless we develop a support group, this concern will always remain, because every month when they coming, as Pooja ma'am said, the growth is improving. They're not able to understand the growth and development difference, and they see only the height and weight developing. Probably nothing is happening in example the motor development. So every time they'll ask you the same question. Every 15 days when they come for iris, they ask me the same question. In my experience, every 15 days, they ask me, oh, my child is still not developed head control. My child is not able to sit. Same question they'll ask. So they need to, there is, we need to have some support group. I think we'll talk about it later. So that would be the more appropriate way to go forward in terms of, explaining the parent in concern of the overall development.
Thank you, Rajita ma'am, for that insight. Pooja ma'am, over to you. Since you're dealing with, you have babies.
Yes, I have babies. So, like the common theme, that we're talking about, definitely there is a lack of information. Even, I mean, yes, we're talking about children with special needs, but I feel like all parents these days, we come into this realm of parenting without having any information as to what our children require really, to grow up. And then we have the internet, and we have, our lovely society members, and they read something somewhere and they grab some line out of it, and then that becomes like this is the thing you have to do so your child, grows into Einstein or whatever, right? And I think that is one of the reasons why parents come up with a lot of these concerns where maybe there was no reason to be concerned, So the lack of information, I think, is big. I also feel that we as a profession, we don't have a voice, like we don't have a big voice, So we get overshadowed, like Dr. Rajita was saying, by primary consultants, who really, I mean, we don't talk about medical issues with the families. So are they the ones that need to talk about development? So we really need to have a strong professional voice so we can actually have a collaboration with other professionals rather than a hierarchy, I've been very fortunate. This was pre-COVID, but for 2 years, a group of us ran a workshop for uh, pediatricians, on early detection. So surveillance and screening, kind of, that was the topic. And we had such a great response because even the pediatricians are not aware of what tummy time looks like, and how do they tell the family to place their child in tummy time, and what do they do if the baby is not happy in tummy time, So it was great, and it was through IAP, So various districts, they require these continuing ed, events to happen, and so we were invited to like 5, 6 districts. And then COVID hit, so that stopped. But my point is, there is space for us to, speak up, so that we can have all of these issues being addressed as one voice. All the professionals that are handling this child, if they're all saying the same thing, the parent sort of quickly registers and says, all right, this is what I need to do. But if someone says, oh, don't worry, wait, your child will walk later, they're too young, they'll talk later. And then a therapist comes and says, no, we need to do this today, that kind of then derails the plan as well, And the last thing I want to say is access, like I really appreciate what Dr. Sundar is saying about going into these rural areas where they don't have access to people, to therapists, and I was shocked when I came here and I said, let's put something up online, I mean, I didn't really know what it would turn out to be. And for 5 or 6 years, I've had people calling from really remote places in India, and they don't have access to therapists. They are concerned as a parent, they're concerned very early on about their child, but they don't have access to the right person or the right information. And I don't know how we'll solve that, but that's, I think, one of the other reasons why parents, end up troubled and frustrated and concerned.
Thank you, Pooja ma'am. Ushma ma'am.
Yeah. So I'm going to keep it very short because the previous speakers have answered. Mainly the parental concerns are, I want my child to look normal. And sometimes I find myself telling them, you define normal for me. What is normal? Because there is no such thing as normal. There is no such thing as, abnormal stops here and normality begins. That is the idea that the world has already accepted now, but our society needs to accept. And we are the ones, like therapists, to sort of propagate this idea. Okay. So yes, they want the child to look normal, to others. The child should not be stimming. The child should be playing with other kids. How do we stop the stimming? And that's a whole chapter. I'm like, no, you cannot stop. And I also educate them on, even I'm stimming, at times, or you are stimming, and I catch them, when they're shaking a leg or something. And then I tell them the difference. What is the difference between you and your child? We're all stimming, to get the sensory input. Playing with other kids. So parents generally, what I find is they want this, how to make my child, how to. It's as if we have a magic key. They come with us with the hope as we have some key which we are going to turn on and things are going to be fine. That is, the child is going to stop stimming. The child is going to start mixing with other children. When actually, they have given screen time to the child. I mean, that is one of the concerns. Okay, besides their inherent diagnosis or inherent condition, So I generally, not to blame them, but I try to turn the mirror inwards toward their lifestyle, because I'm a strong believer of, besides a diagnosis, particularly when it comes to autism and hyperactivity and sensory processing, lifestyle is a big contributor. So I generally, gently, politely, firmly, I turn the mirror towards them as to what are you doing at home? How is your child? What is your lifestyle? Basically, in many aspects. Okay. Parents don't want the child to attend special school because obviously then others will talk about them. And then there is this big belief that if you put a child in a mainstream school, everything will be fine. Now, this is the greatest myth. Yes, there are studies. Yes, it's good. But when I say that inclusion, inclusion is a whole other chapter, a whole other topic we have to come out with. But inclusion just doesn't mean put your child in mainstream school and everything will be fine. So I generally give them this analogy that if your child, even if you have let's say a normal child or a child falling on the neurotypical, range, and if they're not good in math or they're not interested in math, are you going to put them in an engineering school? No, you just cannot. Maybe the child has other strengths, not necessarily engineering. So this is the way I make them understand through analogies, because otherwise for my population, the ones at whom I see right now, it's quite difficult because the child is walking. I mean, most of them, there are children who are not walking and, they have learned walking here with me, but large part of the population, but they're walking, physical is all fine. Then why is the child like this? Because it's, that pressure from society. And again, when we talk about screen time, they are like, oh, but, we asked in our society, in the building, are all the other parents, what are they doing? Let's say during the COVID time or even before that. No, we are giving screens. Everybody is giving screens. So we also gave screen. There's nothing wrong in that, And the other thing I think is that parents really don't know what Pooja already said. They have lack of information as to how to raise children. And this goes from the children whom we see, whether with a disability, with a, obvious disability, or the children whom I see also have a disability, but is sort of hidden, or even the neurotypical range. We have a big problem of parenting in today's world. We have a big problem of parenting because we have a whole section of society who find everything from the internet. And obviously we all know what internet is. So, there are multiple, besides our therapy, there are multiple aspects that we need to look at as professionals into the family's life, into the family's lifestyle. What are they doing? How are they living? When are they sleeping? When are they eating? What are they eating? I have numerous questions about this, and from there I dig out everything and then, try to make them look inward, without them feeling that I'm blaming them. I'm not blaming them. I'm just explaining to them. Okay. So this is what it is. Sometimes I find that I need to work more with families rather than actual therapy. That's what I find myself into in that situation.
Okay. Ma'am, since you have touched the word normal, so I'll put my final question to you, ma'am. Like starting to redefining what is normal and the so-called acceptance of society. This is what the child is expected to be. Will my child, go to the college or the top universities? These are the concerns, ma'am. So, my final question is, as a physiotherapist, ma'am, what are you doing to change the understanding of function in children?
Yeah. So I've even heard questions not only about colleges, universities, but even marriage.
Yes.
So the only thing I just laugh, I just smile and I tell the parents, let's look at the next 2-3 years and then think about other things later, because who are we to talk about colleges, universities and marriage? Nobody. I mean, when the child is just 3 and 4 right now. Okay. So, okay. So function, when we say function, as therapists, we deal with function, and function is a very simple word, but at the same time, it is very complex. Something that our society does not understand. What is function? So I explained to them, when they ask me, then what's the point of therapy if you can't cure my child or if you can't make my child normal? So I'm like, your child is going to be functional. So what is functional? Behaving age appropriately in school, at home, in society, eating, toileting, sleeping, working with another child, sharing with another child. Of course, this is all going to be age appropriate, you know, in the age appropriate bracket, standing in a line in the park, you know, while waiting for a slide or a swing, or accompanying, you know, being a part of the family and accompanying, you know, towards holidays and vacations and flights and trains and staying in overnight places and things like that. So this is called function. I say when you see these improvements, you can say that therapy is working, and then we'll work towards a goal. These are not my goals, but these are the, what I call is collateral benefits of therapy that you start seeing immediately. Okay. And also parents, I explain to them that all these things don't come automatically. They don't come automatically to any child for that matter. So with a special needs child, it is even a whole different scenario. And also the third thing I tell them, that learning ABCD, learning letters, colors, numbers is not function. I do tell them. I do tell them very politely and firmly that learning ABCD, no. A child has to go to school for socialization, for social skills, for socio-emotional skills. Learning ABCD will happen. If we take care of the base and if we take care of all these things, it will happen again, not in a linear fashion. Things go hand in hand and parallel, you know, not necessarily in a linear fashion. But learning ABCD, matching pictures, using the iPad, using the computer is not function to me. Okay. This is how I explain what is function and what is not. That's where I have to start from first.
Pooja ma'am, as you said, most of the parents do not understand the difference between what is growth and what is development. So ma'am, over to you.
So I feel very, very strongly about information, you know, because as a therapist, or even forget as a therapist, as a human, I cannot change someone else. All I can do is provide my viewpoint.
Information, right? Yes.
So that is what I have been doing, you know, for the past 7-8 years since I've come back here. Just being a platform for, you know, information. What is the right sort of information? How the parents take it is up to them, you know. At the same time, at work, you know, we've been able to, like I said, come up with a really nice program where, you know, surveillance is now part of every visit, you know, every very baby visit. There are screenings done regularly. Of course, I only do the high risk, but obviously it has spilled over to the other pediatricians, you know. So just in the few years that I'm working at this place, now I see referrals coming in much earlier than they used to before. Also because of the way we work, where, you know, we are very play-based, very home program, you know, play-based functional activities. We don't have so many babies who are going away with not walking, you know, past 18 months. We are very much able to keep track, especially with motor. Unfortunately, I don't have enough of a team. So there are definite, you know, delays with language, as I would have. I mean, I wish we could have done a similar, you know, program for language as well, but there's only so much I can do. And in general, I feel like as a therapist, that would be my goal, just to have these kind of conversations, you know, because again, I feel like new therapists, because we do have some, you know, students walking in sometimes, or, you know, I'll get called from, you know, some therapist somewhere because I'm in a NICU or wherever. And I feel like we need to have open conversations, you know, within our profession as well. We are diverse. Our population is diverse. Our culture is diverse, even though we are in the same country, you know. So we need to have discussions. We need to have papers coming out like Dr. Rajita is trying to do. We need information from our country so that we can build our context, you know, and then come up with guidelines that work for us. We usually end up using things, you know, that are not done with our population, you know, studies or even tests or tools that have these cutoffs. You know, ASQ is a very popular tool that is used, but the cutoffs are based off of American standards, and our population really doesn't work like that, you know. We have in the NICU, we have guidelines for skin to skin care. You know, they say 30 minutes, 1 hour. Our mothers live in the NICU. We can do 8 hours, 10 hours of KMC. What is that doing to our babies? You know, So we really need to have information that it sort of is what's happening on our in our practice settings. So I think as a therapist, that's where I would like, or what I do in the sense to improve things is just having these conversations with anybody who's willing to listen.
Thank you, ma'am. Rajita, ma'am, what do you, ma'am?
I think the first thing I can think about in terms of changing the function among the children, especially when you're considering the chronic childhood conditions, we'll have to develop a sustainable and an inclusive rehabilitation model. That's the first thing I can think about in terms of treating chronic childhood conditions, be it cancer, childhood cancer, or nephrology. Until unless we cater to an inclusiveness or sustainability of rehab, I don't think so we can really target our parents per se. Another thing we have to, as I mentioned earlier, also we have to educate our services to all these specialty consultants so that we can empower our parents. Another one of the example I would like to quote here from our clinical practice that wherein we could successfully initiate some multidisciplinary clinic or a comprehensive specialty clinic called Pride, wherein we sit all the specialty consultant, all of us, we sit under one roof, and we try to translate all the information to the parents and the family in under one roof. That actually gives the parents or the family really good understanding in terms of the function of the child. There is no difference of opinion from a neurologist or an orthopedic point of view or a psychiatrist point of view or as a PT point of view or a speech and language development. So these kind of initiative in our profession would actually take a long way and would really help us in terms of again coming back to the inclusiveness. So what happens otherwise when we work in a silos is where actually all the parental concerns, family concerns, all those are, that's not the whole gamut, but this is one of the aspect. Many of our panel member, both of the panel members spoke in different aspects, but this is the one of the aspect we can actually way we can overcome the parental concerns or the family concerns, I believe. So actually this Pride clinic, specialty clinic, has taught us a lot of things, how to mainly tackling the parental concerns and the family concern. Likewise, if we could build up such kind of a comprehensive specialty clinic for a different chronic childhood condition, I think we can cater to a lot of concerns. That's what I would like to say, Sharon.
Thank you, ma'am. Sundar sir, you will be the last to answer, and post which we'll open the discussion to audience. So I would request if we can keep it brief and then open it for the audience for further any queries.
Okay, so I would summarize a little bit here. The number one is information. People talked about information. Dr. Pooja talked about information. Now, when I look at information today, at 21st century, there is a lot of information that is available, right? You go to an internet, type about sensory processing disorder differences, you would get a lot of information there. You type about cerebral palsy, you will get a lot of information. The problem is families do not understand these information very well, right? Now, that's where, as a practitioner, it's important for me to sit with them and try to make them understand how it's going to be. Now, if I see a child with sensory processing differences, I need to make them and understand this whole thing. Unless and until the family is empowered, we are not going to go anywhere, right? We are going to stay there. It's not going to be a hierarchical model that the therapist is the leader of the entire team. No, the family is the leader of the entire team, right? That's how they are going to. The family is the one who decides everything. So it's very important that they are empowered with information. Even though there is a lot of information, they really do not understand. Simple example is just go back to your child whom you treat with sensory processing difficulty and ask a family, what is sensory processing difficulty? They would not be able to understand it. They will not be able to answer it. Why it is because most of the times they do not understand, even despite of reading pages of information from the internet. So that is number one thing that I would say that we are the ones who are interacting with the family on a daily basis, are responsible for giving that knowledge empowerment to the families. That's pretty important. That's number one. Number two is Dr. Pooja talked about voices. I would say that is very important. There are many therapists who are sitting here. Voices are very important. We need to have a voice. I have been through that path a pretty long time, right? Struggling with putting your expertise among the people like developmental pediatrician, orthopedician, and then neurologist. Now, how do you put your voices? The only way you can put voices, the way I put my voice is to show my work. Show my work with children. Today, if my child goes to a neurologist, the neurologist asks only one thing, right? Whom do you go for therapies? Sundar, yes, great. I don't need to tell anything. If you go to an orthopedician, he says that I don't need to tell anything because now he knows everything. You go back, you're in the right place. Whatever he says, you follow it. So they don't give instructions. They know that we are an expertise in movement, and then we are the leaders in that, and then we would be able to provide an excellent care and services to our children. So they don't interfere in our work, but they would collaboratively understand that what they need. An orthopedician can always say that. My orthopedician says that, okay, Sundar, do you think we need to do a surgery for this child? What do you think about it? Now that is a kind of a level everyone can come. But where does it start? It starts from the way you start producing work. I'm not saying that you're going to make the child run. No, that's not the point. Your quality of care would speak for itself. And when the primary care practitioner sees your child or follow up, you can really understand what is the quality of work. You don't need to go and speak to them, but by seeing the child, they would understand the quality of it. That is the starting point of creating voices. And it is not enough only Sundar or Dr. Pooja or Usma ma'am or Dr. Rajita are doing this. No, everybody has to do it. It has to be a collective voice for people to see our expertise as a collective community. 1 or 2% are not going to make difference. It's the collective community that makes a difference. Now that is what I want each and every professional working with children has to do. So those are the 2 points I want to end up with.
Thank you, sir. Usma ma'am, you're on mute.
Ma'am, you're on mute, ma'am. Can you unmute?
Oh, I'm sorry. So one last point I wanted to make here as a continuation with what Sundar said is that as therapists, it is our obligation to convey to the families using very simple language and simple words that they understand. Here, I don't mean their local language or their maternal or mother tongue, but even if you're talking in English, even if the parents are highly educated, you need to talk to them in very simple language. Basically convert your therapeutic lingo into simple words for them to understand. Then they will remember. This is where I have been very successful at, and parents understand because they say, now it clicked to me because you explained to me like this. Okay, so yes, we are therapists. You can use your language in your reports, documents, when you talk to other doctors, other therapists, etc., etc. But to parents and to families, they need